Hi and welcome. Class 2021. I'm Dr. Seema Nanda, the CEO and Director of the Nanda Dry Eye and Vision Institute in Houston, Texas in the United States. Today we're going to be talking about contact lenses and the aging eye. A lot of us don't really expect, patients to be wearing contact lenses as we get older, but they've been wearing it when they were younger, so why wouldn't they wear it when they're going into their seasoned years? Now, why would a person wear contact lenses as they get age? Why would a patient or why would a person want to wear contact lenses? Four main reasons. Number one, cosmetic. Everyone wants to look good. Even as we get older, they get rid of wrinkles with Botox. Why don't we get rid of some glasses with the contact lenses? Their visual demands also change as we get older. And those demanding changes have to have modalities to fix that, including multifocal lenses, soft or hard, or gas permeable, or even scleral options. Refractive needs changes as the eye changes as well. One of those refractive changes could be cataracts. Another could be the lids. All these things are important to understand with the aging eye. And the last is a therapeutic need. You don't think about contact lenses as a therapeutic option, but it is. And just as this joke says, to be old and wise, you must be first young and silly, or stupid. Let's not be stupid today. Let's learn a little bit more about the aging eye. Now, first off, cosmetic. Now, usually when we look at older patients or older populations, we see people in wheelchairs or walkers or those things that maybe you perceive a patient to be. Those people, presbyopic, we know they're over 40 or around 40 plus or minus a few years. Middle age, we start thinking around 50. Those who are seniors are considered to be around 60 plus. And then retirement age, 65, 70, 80. People don't even retire. They still work till they die. So is there really a retirement age? Well, now we think 60 is the new 40. How do we know that? Look at this beautiful woman, Jane Seymour, in her 60s, dancing with the stars, in a beautiful gown. You do not perceive this person as an old person. Well, they are, and their eyes are aging too. So you've got to be ready for those options. They don't want to wear bifocal, segmented, or glasses or anything like that. They want better vision with their contact lenses. They lead an active lifestyle. So in order to be active in that lifestyle, you have to go with the changes too with contact lenses. Now, we look at the visual demands of older patients. When we look at those visual demands, is it really true or is it a stereotype? Do all old people knit? I know 10-year-olds who learn how to knit. It's just something they do. So not old people really think about, I don't even like to say old people. We like to say seasoned citizens. Those people who have seen life a little bit and enjoying it. What about card games or video games? Patients today, young or old, are starting to use laptops, are starting to use mobile devices like tablets, iPads, iPhones. So when you think of an older person, look at their visual demands too. A computer might not just be something in front of them. It could be an iPad sitting in their lap. And their reading demands also change because they're on an iPad. Their eyes can dry out too, especially when they're on a computer. And as we get older, they don't blink as much, just like young people. And if they don't blink as much, their eyes dry out, their contact lenses dry out. So you got to remember those things when fitting a contact lens on an older population. And, it's cute here. It's an iPad made of trees, right? Because all those patients think, Grandma, you can read out of an iPad? Yes, we use books too, but we use computers as well. Now look at those visual demands as well. Some people don't even think about it, but Grandma likes to see, or Grandpa likes to see their grandkids, but they might not be able to travel because, especially in this last year, they might not be able to travel. So what's the best way to look at their kids or their grandkids? Skype. Or some kind of program, a FaceTime or anything like that. They can translate that with their kids. Well, they need to see their kids without having to put their reading glasses on and then have a dirty image because they're trying to figure out where to look. What about Facebooking or texting? You don't think Grandma knows how to text? Well, she does, and she wants to look at her iPhone. Or when she wants to Google a recipe online to find that, latest and greatest ingredient that she missed out when she was a kid. All those things are out there now, and we want to be able to provide those patients with those options of Googling, texting, Facebooking, Skyping, and whatnot. And what about checking their phone or checking the weather? Most older patients like to talk about the weather. Boy, it's a beautiful sunny day outside. Yeah. Or do you know it's going to be raining next week? Oh, how do I know? I can just look on my watch and then click, 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 and I can see. But if I can't see my watch to see, then it's useless. So those patients, young or older, would like to use these different modalities in order to function just like you do. And they want contact lenses to do it. Now, what about their refractive needs? Well, you think they're a bunch of old farts, that's because they're doing their yoga and everything. They don't necessarily, or they can, put distance vision contacts on and then put readers on top. Some people, visual demands are much more than others. They may need more lighting on their subject. If they need more lighting and their visual demands increase, reading glasses might be the only option they would want, especially with the computer use. What about maybe they don't need as much demanding thing? Maybe they can just look distance as well as near with a monovision option. So one contact for distance, one contact for near. And some people say, yeah, that's good enough. I can see my watch and I can see my computer and I can, see to drive. But some people say, that's just still not good enough. So what can we do for those people? Modified. So a modified monovision would be maybe a bifocal in one eye and a distance or intermediate in the other eye, depending on their demands too. And some people say, I can't, I can see near and I can see far, but I lose that intermediate. Maybe with a modified monovision that can help. And of course, the last obvious reason, a multifocal. A multifocal contact lens could be the best option for all of it, where you can see the distance, intermediate, near, where you can fit distance in one eye and intermediate, and then maybe intermediate and near in the other eye. There's different options that can go with fitting those lenses. It can be a soft lens, it can be a gas permeable lens. Either or, whatever the patient has been wearing before, you can just add it as they get older, or if they're new to contact lenses, that's also a great option. Now, therapeutic needs. This is something that we don't really necessarily think about in a younger person, but an aging eye also has an aging lens, and that aging lens is a cataract. So sometimes one cataract may be bigger than the other cataract. So the patient says, yeah, I was seeing great with my monovision, but now I can't see it anymore. Well, let's look at your eyes. And we look in this eye and we say, wow, the cataract's so much bigger in this eye. And then they have a different complaint. They're anisometropic, meaning one eye may be nearsighted and one might be less nearsighted or whatever, because the cataract's causing that change. Or let's say they have the cataract taken out. Maybe they have a pseudophakic IOL put in and that can help them, but they're disparate between the two eyes. Or maybe their vision was so bad that maybe they were so nearsighted that end up being aphakic after the surgery. What about those patients who've had, what about those patients who've also had surgeries in their younger years? There are a lot of patients who had refractive surgery like a radiokeratotomy maybe 30 years ago, and now they're 70 years old and you see these arcade incisions. Those things make a difference, especially on older population where the vision changes on the corneal surface because they change, because as we know, arcade incisions never quite heal. They're always healing, healing, healing. So they become a hyperopic shift. What about those patients who had PRK or LASIK? Their corneas may be flatter than a normal patient. So a contact lens fitting on those patients might be a little bit more difficult. They had great vision when they're younger years. Now they're getting older, cataracts developing, can't see as well, and want to try a contact lens option.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
What if something happened? What if we had a bad result? What if we had a pupil that's not the same size in one eye versus the other? There's other reasons that patients want to wear a contact lens to hide that mistake or that injury, that trauma to the eye. So a cosmetic lens to make colored lens with a clear pupil so the patient can look out of so it looks normal in both eyes. So those are the other reasons a patient might want to wear a contact lens. Now, other therapeutic reasons are something that we don't really think about. It can be older or younger. Those type of patients are those who have, let's say, a recurrent epithelial or recurrent corneal erosion, where their eyes get so dry as they blink, 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 or they try to blink in front of the computer or whatever, and then all of a sudden, their eye rips open. And because it rips open, and especially when we're older in our population, their eyes are drier than others. So when they have this, what we call recurrent erosion, it might be hard to manage the pain. It might be hard to manage the condition and protect that compromised cornea. So what can we do? A bandaged contact lens might be that in order. So when you look at those patients who have recurrent corneal erosions, who have had a history of a chemical burn or a trauma or even severe keratitis, what can we do for those type of patients? And what about those patients who have normal corneal function except for their lids look weird? Why? Because the involutional changes that happen in the lower lid, they can turn in or become entropic or entropian. And then all of a sudden, those lashes which were out before now are pushing in and scraping up that cornea. A bandaged contact lens might protect that if they haven't had time to have the surgery to push their lids outward. Now, what are the FDA approved? Well, at least in the United States, FDA means the Federal Drug Administration has approved these contact lenses for use to protect the cornea, or FDA bandaged contact lenses. Why do we pick one over the other? Silicone hydrogel versus hydrogel. Well, silicone hydrogel, these are the three different ones that can be used. Silicone hydrogel have higher oxygen content in them. So if a person has to wear the lens for 1 or 2 or 3 days, maybe, at least there's a higher concentration of oxygen. But because there's a higher oxygen getting through, the problem is the lens dries out. And in an older patient, that might be hard, especially keeping the lens lubricated. Now, the other thing is, do you fit it tight or do you fit it loose? When you put a contact lens on, well, you want it to move. But for a silicone hydrogel, it doesn't really matter if it moves or not, especially when you've got a patient who's got an abrasion. If a patient has an abrasion, that means if the lens is moving, you're ripping up that eye again and again. So kind of you want a little bit snug. You want it a little bit tighter, so or at least not moving as much. So if a patient blinks, the lens doesn't move around and it doesn't rip again. So you want it looser. No, you don't want it. You want it a little bit tighter, and you don't worry about if it's fitting too tight or not because of the oxygen. And what power to use? Well, if they have a prescription, you might want to put their prescription in there. If not, just stick with around the Plano, plus 50 or minus 50, whatever. Sometimes if you give them a minus 50 on a cataract patient, it gives them a little bit more, like, I can read up again. And then all of a sudden they say, maybe I want this in a contact normally. Now, what are the other options that we can treat with a patient with a recurrent erosion? One of the big things in the United States right now is a cryopreserved amniotic membrane. What that looks like is just this membrane that sits in this ring that covers that eye that's been damaged. And the amniotic membrane comes from the baby, and it has nutrients in it to regrow and regenerate those corneal nerves, especially in those patients who have a little bit of a dry eye. So it can regenerate that corneal nerve, help that person heal, and that recurrent erosion may never come back again. So when it does it, it also has these properties that decrease blood vessels, so you don't want these blood vessels growing into an area that doesn't have it. It has anti-inflammatory properties, as well as it reduces the need or reduces the amount of scarring that might happen when a recurrent erosion heals up again and then scars. So these are the properties of a cryopreserved amniotic membrane that might be great for those patients who have a dry eye, who have recurrent erosions, to close it up and then maybe fit with a contact lens to help them see better again. Now, when we look at also something else, which is the lid anatomy. Now, when we look at the lid anatomy, we know on a younger patient, patients blink, they do normal functions. But on an older population or an aging eye, we have to look at the muscle tone. It loses elasticity, kind of like a rubber band. If you snap a rubber band, after a while, it becomes more and more flabby. Same with the lids. They become flabby because we've used them all our lives. The other thing can happen, it not only loses elasticity, it can have extra skin here, and it becomes heavier and it droops down a little bit more. Now, what we don't realize is a lot of the times these patients also they don't have to impress anybody anymore. They don't go out as much, or they stay inside. So they might have a little bit more poor lid hygiene than, let's say, a younger population. And that's just a factor of age. So what can we do? There's many things that can go alongside those patients who have poor lid hygiene. There are many other things that can go alongside with those patients as they age. Comorbidities. There's certain things that people have when they're older as opposed to they're younger. high blood pressure, diabetes, things like that. So we need to make sure their eye examination is done on an annual or maybe every 6-month basis, just to make sure everything's going okay on the front of the eye as well as the back of the eye. The front of the eye could have changes with the lids, but they can have changes with the lens as well as the retina. Diabetes, macular degeneration, age-related changes, age-related things. So we need to look at those. Now, when we look at the lid anatomy, what I was telling you before is looking at the lids themselves. Sometimes one lid might be lower than the other lid. And why is that happening? Because of that loss of elasticity. Again, you've been blinking your whole life. Who knows? You could start losing that, flabby. Just like muscles here get flabby, just the lids get flabby. So the levator, or the elevator, I like to call it, the levator palpebral superioris is the main muscle of the upper lid, and it causes it to move up and down. Well, one may not get the same neural function as the other eye, and then looks like it can be bilateral ptosis or lid droop or one side. Another thing is because the heaviness, as we get older, the weight of our lids comes down. Gravity brings everything down, including the lids, and that might cause dermatochalasis. Another thing, which is called blepharochalasis, is because the lens Another thing, which is called blepharochalasis, is they lose the Let's change that. Another thing is called blepharochalasis, and blepharochalasis is similar to dermatochalasis, except for the lids get puffier. They become more thick, more swollen, and then it almost has this very thin appearance, almost like a cigarette paper. That's what they call it. So dermatochalasis is the heaviness, blepharochalasis includes the swelling. And then the last thing, what if they had the blepharochalasis or dermatochalasis, and then they fix it? And then now, all of a sudden, their eyes are wide and tight. And so when they try to blink, they don't have complete coverage. So they have exposure. They might have exposure keratopathy going on because they don't have complete coverage. Or their lids are so tight that when you put a lens on, it grabs it so high up there that it doesn't sit down. And all of a sudden, it doesn't translate. The normal bifocal contact lens that they were wearing, or the gas permeable that we're wearing, which we're translating, all of a sudden are stuck up there because the lids have changed their contour, and then they can't bring it down normally. So those are the lid anatomy of those patients who have either a droop or the fix the droop. Well, what if they don't have a droop? What if they have something else? What if their eyes are really bug-eyed, okay? This is Graves' disease, or exophthalmos. So exophthalmos have bigger, or what we call scleral show. The white part of the eye shows at the top and the bottom. And because of that scleral show, because those patients have hyperthyroidism, fitting a contact lens may change. So all of a sudden you put a contact lens on that patient's eye, and then they can't blink enough to cover that eye, or they can, but their eyes are so dry because it's being exposed to the air and the contacts much more wider than somebody who has smaller fissures. So maybe a GP option might be better, which is a simultaneous lens versus a soft lens option, single vision, monovision, or bifocal. But whatever it is, you've got to watch about whatever it is, you have to watch out for the dryness that can happen with those exophthalmic eyes. Hopefully you don't have too many of those. Now, we've talked about the anatomy. Let's talk about actually the cleanliness of the lids. If you look at the lids themselves, have the patient look down. You really want to look at those lashes. If those lash margins have a lot of debris, it could be one of three things. It could be Staphylococcus aureus, or epi, Staph epi, Staph aureus, or even Demodex. And Demodex is very, very prevalent in an older population. Why? They sleep with their dogs, they sleep with their cats, whatever. They say there's non-cross-contaminant, but I do see a higher predilection in those patients, maybe just because they miss their spouse and Fido has to be in the bed with them when they go to sleep at night. Regardless, those populations also have a problem keeping their lids and lashes clean. Now, that's the top part. That's anterior blepharitis. What about the bottom part, or posterior blepharitis? Those type of patients have what we call meibomian gland dysfunction. So what happens there is the actual lids, or the actual glands, the meibum, get clogged. And when they get clogged or inspissate means to turn into a gel. So it's going from a thin liquid serous, like an olive oil, to a thicker, more gelatinous, more like a lard or a Crisco, something like that. So it's changing. And as that composition changes, it affects the coverage of the tear film. So let's look a little bit into what we can do about those type of patients. For the anterior blepharitis, there's lid scrubs that are out there. They can massage their lids, get rid of the debris, and keep their lids and lashes clean. If they keep their lids and lashes clean, they can wear their contact lenses a little bit longer than normal, because they say, I can only wear it for 2 or 3 hours. Clean the lids, maybe it becomes 4, maybe it becomes 6. But what if they have the anterior blepharitis with the posterior blepharitis? With posterior blepharitis, what we want to do then is maybe put some heat on there, melt those glands up, allow that to dissolve, and when it dissolves, they'll have a cleaner tear film. Warm comforts, what about nutraceuticals or omega-3s? There's been some controversy about that, but it has an anti-inflammatory property to it, which can also help those lids. Another thing is putting an ointment or macrolide that will dissolve those thick glands to make them thinner and more serous, like the olive oil we mentioned before. Now, when we look at those deficiencies, when we look at a meibomian gland deficiency, we're looking at the lipid layer. So that's the top layer. Okay, so when the meibomian gland doesn't produce that lipid layer, you have an increase or decreased tear breakup time. That means when you blink, within 3 seconds, all of a sudden, it's gone. The tear film is gone. Another thing is the aqueous gland behind. The lacrimal gland produces the aqueous. And if So when we look at the next layer, we look at the aqueous deficiency, and that's produced by the lacrimal gland behind the eye. When we look out here, if they have atrophy as we get older, they wrinkle up just like our face wrinkles up, it shrivels up back there too. It doesn't produce the quality tears that we need for the patient to function. So there's a dry eye deficiency because of the aqueous deficiency. The other thing is the goblet cells on the conjunctival surface also get older as we age, and then there's a mucin deficiency. And when there's a mucin deficiency, those patients have that stringy or filamentary type keratitis. Well, that's definitely not conducive to wearing a contact lens. So you want to keep that mucin layer intact through other things like cyclosporin can improve that function, as well as the aqueous deficiency. And then, of course, you have exposure keratopathy because the patient has a lid that's coming down a little bit too much, called lag ophthalmos, or maybe from the ectropion that might happen as we get lid laxity and the lid comes down a little bit. So you might have to do kind of a tuck or a mini tarsorrhaphy to tighten those lids up to help those patients in order to wear their contact lenses. Now, contact lens related dry eye, of course, can also produce things on the contact lens. We can have protein deposits developing on the contact lens surface, especially if those patients don't clean their lenses often or don't wear a disposable lens option. So wearing a contact lens, make sure that they clean the lenses every day if they're not wearing disposables, or switch them to a disposable option. That can help. Another thing is keeping that clean surface of the lid or the lashes will also help those patients, and then improving their tear function by giving them either aqueous deficiency medications like cyclosporin or lifitegrast, or even giving them artificial lubricants that might help those patients. Blurred vision might be a cause of that. So the patient says, I was seeing well with these contacts and now I can't. And then you look at the contact and you see this full of deposits. Well, of course it's full of deposits because their eyes are getting dry, or they're not cleaning them. So remember that. Variable vision might not be that the vision's actually changing. It might be just the contact lens is drying out. And then if they're wearing their lenses too long, as they wear them and they develop these deposits, if you flip their lid and look under there, look for GPC, look for giant papillary conjunctivitis. And when you look for those things, you can say, okay, now I see that, I might have to put you on a soft steroid or an antihistamine and to decrease it so you can wear your contact lenses a little bit longer. However, when you put them on an antihistamine, guess what? your eyes are going to dry out again. So you got to watch that too. So keep them lubricated, keep them on those antihistamines if you can take them off, or I'd rather have you just change out the contact lenses and switch them to a disposable option if that is an option, because wearing time is definitely going to be reduced. Now, something we don't really think about, we always think about the eye and the anatomy of the eye. What about the hands? As we get older, we get more arthritic. When we look at those patients, when you shake a patient's hand, look at the joints. See if there's rheumatoid going on. Their dexterity might not be the same as that when they were younger. And when they were younger, they could move around easier. Now they're stiffer. Things are stiffer. Their arms or fingers are stiffer. It might be harder not only to see the contact lens, but to pick it up without shaking and putting it on their eye. So that's something we don't really think about is dexterity, especially with Parkinsonian type patients. Maybe early on in Parkinson's, they have a little tremor, but as they get older and older, that might be much harder. If they don't have a caregiver to put a contact lens on, Parkinson patients have an issue. Even MS patients have tremors as well. What about balancing issues? You know, they have to go to the bathroom and you have their walker in there. Same thing. All of a sudden, you're telling them to put a contact lens on and they can't even hold themselves straight. So a balance issue might be an issue. A balancing problem may be an issue when putting on a contact lens because they lose their balance. So that means something. So all three things can also happen together. You could have a balance issue, they can have tremors, they can have the rheumatoid. It's really hard when all these comorbidities exist in one patient. So look at that when the patient comes in. Make sure you pay attention to that. As we get older too, there's inflammatory conditions that we start thinking about. Lupus is one of them. The whole body is inflamed. Same with rheumatoid. The whole body is inflamed. If the joints are inflamed, by golly, the eyes are going to be inflamed too. So you have to pay attention to that too. If you see the inflammation around the eyes, the redness, the swelling, the irritation, ask them if they have any systemic problems. It can reduce the tear film and thereby cause a problem with the contact lens wearers as well. Now, what about oxygen demands? So sometimes we don't think about a diabetic having poor oxygen demand. Well, what happens in a diabetic patient is that there's sugar in the blood. And if there's sugar in the blood, there's less oxygen in the blood. So there's a lot less oxygen. They're going to be those who are going to be poor wound healers. And they're going to also have poor oxygen coming into their corneal surface as well. So you put a contact lens on top of that, put your lid on that because they blink and everything. That can be harder on a patient. So watch those patients who are diabetic. They might not be great contact lens candidates in and of itself. So see if they have diabetic foot ulcers. Ask them if they have any issues regarding that as well. So watch those things. Something that we don't think about either is cognitive status. Sometimes they seem pretty good in the chair, but you don't realize that they're having maybe short-term memory losses. They think they've not put their contact lens on. I had this patient. She wore 6 lenses. She put her contact lenses on. She's got disposables, so she puts on a new lens every day, and then she comes back in a month. She's like, I just can't see anymore. I think my cataract's worse. And then when you look at her, you're like, you took one out, you took another out, She kept forgetting to take out her lenses at the end of the day. True story. So sometimes that short-term memory might be a problem with an older population. Their cognitive issues might be an issue as well. Change that. They might have cognitive problems that might be an issue as well. One of those things is maybe early Alzheimer's. They don't know that they can't remember certain things, or they thought they did something and they didn't. Like I said with this patient who couldn't remember. She puts on a contact in the morning, but she can't remember to take them off. She might start having, again, the tremors as well, what we were saying with the MS or Parkinson's type patients. And what about strokes? They could be flicking off these mini strokes. Now we know with this vaccine that's producing a little of these mini strokes. So when having these patients with these mini strokes, they might not even know that their vision's declining because they thought maybe it's a cataract, but actually they had a TIA or transient ischemic attack and their vision went down. So those are the things you have to worry about. Like it says here, some days I just wish I had the wise person of a 90-year-old body, the agility or the strength of a 20-year-old, but the energy of a 3-year-old. Sometimes I feel like that too. So eye exams for the elderly, what we have to make sure is there's no contraindications, that if they have blepharitis, either anterior or posterior, if their eyes are dry with KCS, or just even a conjunctivitis if they have inflammation to the eye. Or what about just poor patient compliance? They wear their contacts sometimes, they leave it in the case, and then they forget about it, and a month later they put it on and they get an infection because they forgot how old the lens was because it's sitting in the case, and they don't even wear disposables. Their eyes can become drier as they get older, and their eyes can become drier. So when we look at decreased vision, we have to understand why we have decreased vision. Decreased vision could be because of the dryness of the eyes, and the dryness of the eyes could be leading to contact lens wear drying out. The other thing is cataracts could also decrease the vision because all of a sudden they were seeing great and now one eye sees better than the other, like I was telling you before about monovision. Glaucoma can also have effect, not necessarily effect of the vision, say distance-wise, or let's say center vision wise, peripheral vision can be affected, and all of a sudden they say, I didn't see this car coming, there's something wrong with my bifocal contact. No, it's the glaucoma that's deteriorating your peripheral vision. The other thing with glaucoma is the medications they're on. Sometimes they're on medications that have BAK or benzalkonium chloride, which is very corrosive to the they have BAK, which is kind of corrosive to the cornea. And if you're using that every single day, it can cause SPK or punctate keratitis on that corneal surface. And then you're putting a contact lens on and they're wondering why their eyes are always hurting or dry or irritated because of the glaucoma medications, not just the vision. So when you look at those patients with cataracts, you have to look, okay, is it decreasing their activities of daily living? Maybe it is. Or they're noticing, especially driving at night, there's so much glare coming in. So they're thinking the contact lenses are drying out and maybe causing that glare. Or is it because of they think it's the contact lens causing the glare, or is it really because of the cataracts causing the glare because they have a posterior subcapsular cataract that's causing it too. Decrease, no improvement with the pinhole. When they show the pinhole and see if that improves, it's no improvement. Or with the brightness acuity test, that's showing no improvement. So maybe it's time to have the cataract surgery. Now, when you have cataract surgery, you got to watch these patients one day post-op. You got to make sure there's no cells and flare in the eye. You got to make sure that the anterior chamber depth is open enough. Otherwise, maybe there's wound closure. If there's any cells and flare, you have to watch those things. And then you have to make sure that those patients are still taking their medications, whether it's antibiotics, whether it's steroids or whatever. And then they can't wear their contact lens, but maybe they don't need to after that because they've had the cataract surgery. So those are the things you have to consider with the aging eye as well. So ready, set, go. How to be successful. Are we ready? All right, here we go. Successful elderly patients with contact lens wear. High motivation versus poor motivation. If they don't have a support system, if their daughter, sister, brother, uncle, whatever say, why are you wearing contacts? What? You don't need to be wearing contacts. And they're like, but I want to do that. So if the patient's motivated enough, but they don't have the support, maybe if they are Parkinsonian and they can't go in it, if they don't have a family member to help them wearing contacts, then they're going to fail. So we want them to have success. If they're motivated to do it, we'll figure out a way to help them wear those contact lenses if they want to do so, even if it's just going to a social gathering. Sometimes that's just all they want. Get their daily disposal, or even a contact lens, it's a color lens. He's like, I want to make my brown eyes blue. I want to go to this gala. Every older person loves going to a party. Every younger person loves going to a party. They want to look good. They want to look young. They want to look healthy. If they're motivated, help them with their support system. Find out who their family members are that can make them succeed. Number 2, to get successful, good personal hygiene versus poor hygiene. Again, look at those lids and lashes. If you tell them, if you want to wear contact lenses, you got to use your lid scrubs every day, morning and night. If you don't do it, it's like brushing your teeth. You want to keep your teeth clean, to smile those pearly whites. So when you smile those pearly whites, you want those patients to have the pearly whites of their eyes. So they want to see the beautiful eyes. Keep their lids and lashes clean. If they're motivated to keep their lids and lashes clean, they're going to be motivated enough to wear contacts. Another success. Why you want to have success? Good manual dexterity versus poor dexterity. So if you have a patient with a lot of tremors, they might not be a successful candidate. But if they have that support system, or if they have somebody else that can help them wear the contact lenses, that might be okay. But if you just see them, they have their tremors in their hand, and you see them, it's harder for them. You don't want them to scratch their cornea. You don't want anything detrimental to happen to them. So see how they are in the exam room before you start thinking about, yeah, you can wear contacts. Look at everything to make that a successful candidate. And then what about adequate eye health in general? You want them to have good ocular health versus somebody who doesn't. If they have chronic lid diseases of the cornea or the conjunctiva, that's going to be a problem too. Now, the last thing and the most important thing, is it realistic for them versus unrealistic expectation? Just because you're happy, you're like, look, all we have to do is clean your lids, all we have to do is clean your lashes, all we have to do is have somebody help you if you have the tremors, all you have to... Now, that seems so many all you have to do's. But that patient might not have that. They think, well, I just wanted to wear contact. I don't think I want to do all this. So that might be unrealistic for them to go, I can't do all these things, or I'm not motivated enough. So just because you produce that option, yes, you can wear contact lenses, make sure they're on board. So if you're happy, then the patient's happy. And if you're on the same target, then you'll have a successful contact lens wearing patient in the elderly. So remember, there are different reasons why the older population would like to wear contact lenses. It could be cosmetic. It could be because their visual demands have changed. It could be because their refractive needs have changed. Or it could just be a therapeutic option if they have trichiasis or ectropion or exposure or all these different things. Once you understand why that patient wants to wear it, once you understand that the aging eye can also wear contact lenses, you too can be successful in treating those patients. So thank you so much for joining us today at Class 2021. This is Dr. Seema Nanda of the Nanda Dry Eye and Vision Institute here in Houston, Texas, United States of America. Thank you, and wishing you every success in contact lenses and the aging eye. Thank you.